Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Hi everyone, pleasure to be here. I'm Andre Tomlin from the Mental Health, and we're going to talk about developmental language disorders and young offenders and reoffending tonight. Really interesting piece of research led by Maxine Winstanley, who's with us here at the Campfire this evening. So if this is a first time here, welcome. This is a very relaxed, thought-provoking online journal club that we're going to run for the next hour. And as Matt says, we've got a couple of hundred people here in the webinar. And first of all, if you could share poll one, Matt, we want to know who you are. So thanks a lot for introducing yourselves in the chat. Carry on doing that. Tell us what your background is, what your primary role is attending this event. There's a poll that's just popped up in the screen. And hopefully your kind of professional affiliation appears on that list. If it doesn't, there's an other at the bottom. But we just want to get a sense of what kind of people we've got here in the webinar this evening, so we can make the session as specific and relevant to you as possible. Fantastic. So that's great. As expected, we've got nearly half of the audience are speech and language therapists, so that's brilliant. Wonderful to have such a great response. I think this is the best attended Campfire that we've run so far. So yeah, big up the SLT community. Well done, guys. Really nice to have you joining and discussing this with us. And yeah, you can turn that off, Matt. We don't need the slides just now. We can make do with yeah, pictures of human beings for the time being. Thank you. So I'm just going to introduce people who are here. First of all, Dr. Maxine Winstanley. She's a speech and language therapist. She's the course leader for the master's course in SLT at the University of Central Lancashire. And she's our kind of guest speaker talking about her research. So you'll be hearing from her very soon. We also have a forensic and child and adolescent psychiatrist who many of you will know, Dr. Richard Church. He's the hospital medical director at Signet Healthcare and has lots of experience in this field. And two of my colleagues here on the Campfire, an information scientist and fellow ELF, Douglas Badenoch, who's going to be here this evening talking about the paper and giving you lots of critical appraisal tips and thinking about the strengths and limitations of this research. And also our colleague, Dr. Celine Reichardt, who's a psychiatrist and researcher from King's College London, who's part of the team here, who's going to be working in the chat and helping us make sure we answer as many questions as possible. So first of all, many of you will know this area very well, some of you less well. So we thought we'd start off by setting the scene. And I wanted to start by asking Richard to give us a kind of psychiatrist service perspective on this population of people, young people in the criminal justice system who may or may not have developmental language disorder, people who are offending, maybe reoffending. Just paint us a picture, Richard, of the lives of people and yeah, give us a sense of that.
Absolutely, and thank you for inviting me to be part of your Campfire. I'm really pleased to be here. And it's really great news that there are just so many attendees. When I saw the attendance poll, I thought, wow, that not just really impressive to see so many speech and language therapists, of course, but just to see the breadth represented there. I think that's a real strength of ACAM. And I feel very much in the minority here as a psychiatrist. And that's a very healthy thing, I think, for me. So to be honest, I hope that I'm enriched by today, really. I hope to learn a lot. And if I can share something that might be useful or interesting to someone, then fantastic. But let me tell you a little bit about my medical or psychiatrist's perspective on this area, including speech and language therapy. Because actually, if you'd asked me 20 years ago when I was at medical school about speech and language therapy, I would have probably guessed it was something very specialist and very niche, and that I might not really come across in my professional career. had a very limited understanding of it. But I guess during that time, during the last 10 or 20 years, my understanding of speech and language therapy has developed. And I think from everyone I've spoken to and everything I've read and seen, I think speech and language therapy itself has really developed. So that 10 years ago, when I was a forensic psychiatry trainee working in a high secure hospital, I had the good fortune to come across a speech and language therapist working there, Karen Bryan, who really opened my eyes to this very specialist area, and the fact that as providers of the service, we'd been designing services with the convenience of those delivering the service in mind. For example, delivering groups, therapeutic groups to patients. Well, it's very cost effective and quick, and it's a sort of big ticks, fantastic, very convenient. But actually, are each of those individuals in that group able to engage and benefit from that intervention? I think it was really speech and language therapy that highlighted that actually we were delivering interventions that perhaps really were not having the impact that we wanted them to, that the individuals that we thought we were treating actually maybe were completely unable to engage in the therapies that we were happily delivering. And I think when I started working in the more specialist field of youth offending services, then it was really a discovery landmark moment, maybe an important time in speech and language therapy itself, when they became part of the multidisciplinary team actually in youth justice settings. And actually, I came to have a more day-to-day working relationship with professionals in this field. And of course, I'd worked a lot with clinical psychology and other therapists, but there was something just very specific about speech and language therapy that made it particularly interesting and relevant, especially in youth justice. And I think that's the point where not just in the youth offending teams in the community, but also through expert witness work in the courts, actually, through the work of intermediaries and so on, that I came to that deeper understanding. Yeah.
Thank you.
I thought you were about to ask something, Andre. Yeah.
Yeah, I suppose I was going to ask. It's an impossible question to answer. That's why I'm kind of wondering about asking it. But you can't generalize because it's a very diverse group of people. But people who use youth offender services, tell us something about that group, and are there common issues that they have, or problems that you're helping them with, life backgrounds that you're helping them address? Just paint a picture of that group for us.
Well, I think it would be fair to say that it's a group that's very disadvantaged in a number of ways. We're talking about the group of young people who come into contact with the youth justice system, and we're looking at a disadvantage both in every domain you can think of, really. I think genetic vulnerability to a number of disorders, psychosocial adversity, and disadvantage in educational attainment, sort of impoverishment, really, of opportunity in a number of ways. And I think comorbidity is just the rule, actually, rather than the exception. So the coexisting of mental disorders, safeguarding concerns, all that psychosocial complexity, maybe family or child custody issues, alongside specific or general learning disabilities, and other forms of adversity, not just in the young person, but in their families and in communities. So, of course, it can feel quite overwhelming for practitioners. And the Youth Justice Board publish annual reports, which are very informative, really helpful. We can see that there are some very significant trends over the last 10 years. The number of young people in custody has reduced tremendously, to under 1,000 now for some time. the number of young people being convicted of offences has steadily reduced. First-time entrants have reduced. The area that's remained stubbornly high is reoffending. And this is a particular area of interest for the Youth Justice Service, and actually for those with an academic interest in the field, because there's some unanswered questions. And actually that's, of course, a reason why this article by Maxine is particularly interesting,
Yes.
and deserves the attention that we're giving it here. I think quite apart from anything else, it's an extraordinary achievement to have interviewed 148 young people and completed all 145 young people and completed all those assessments on them, because it's a group that can be very difficult to engage and engage for this period of time in order to do all those tests, and really to see the work that's been done by Maxine and the team is really extraordinary.
Thank you. That's a nice segue. I will take that and move with it. I think so. I mean, for me, the reason this is such a great webinar to be holding it is because this is such an important population of young people who really need help and who are often ignored by research and often, you know, removed from or ignored by services. So great that we're talking about such a disadvantaged population who have so many inequalities that they face. So let's start talking about DLD. Maxine, over to you. So what are developmental language disorders, first of all? Give us an overview.
Okay, thank you very much for inviting me here. I feel really privileged and honoured to be here, and thank you to everybody else who at the end of the start of your working week, at the end of your working day, must be absolutely exhausted, yet you've chosen to come here. So I'm really, really grateful to all of you. So developmental language disorder describes when somebody has persistent difficulties with using or understanding language, and these problems actually affect functioning in everyday life and in educational progress. So developmental language disorder makes it hard for young people to use specific vocabulary rather than empty vocabulary such as stuff and thing. They find it hard to learn new words. They have a very shallow vocabulary, and because of that, they can find it very hard to express themselves, say what they want to say, tell their story, articulate their ideas and their feelings. They find it difficult to produce long and complex sentences. Now, we don't use long and complex sentences to be fancy. We use them because we want to express ideas and link ideas. So, for instance, if you want to say what happened to whom and when something happened, you would have to use a complex sentence to say that. So it really affects young people. So young people with developmental language disorder can have really impoverished narrative skills and find it very hard to tell their story. So if a psychologist wants a young person to tell them something they've seen, or a ward manager wants an account of something that's happened on the ward that day, a young person with DLD may actually come across as somebody who's being quite evasive or holding back, or perhaps a little bit rude, perhaps even guilty. And it's really important that we keep at the forefront of our mind that language is actually a two-channeled process. So we're not just thinking about what these young people can say, their expressive language skills, which is actually reasonably visible to us, but we're also thinking about what these young people can understand, so their receptive language skills, and that's pretty invisible to us. And young people with DLD have a great difficulty processing information, understanding complex sentences, following instructions, keeping up with conversation or social banter. They find it very difficult to comprehend vocabulary relating to emotions or mental states. And young people with developmental language disorder often describe to me as a feeling of really not understanding all the words around them, like quite often people are speaking in a foreign language, or the sounds come at them all jumbled up. and they express a frustration at not being able to keep up with conversations, or not being able to articulate what they want to say, or not being able to keep up with conversations and social banter with their friends. They find that very difficult. And these difficulties can actually often masquerade as or even be attributed to laziness or troublesome behaviour. So it's a persistent, pervasive disorder, and it's diagnosed by a speech and language therapist. And it can occur with other neurodevelopmental disorders. And once again, they can sometimes mask the language disorder. So people may see the autism, but they might not see the language disorder. And I think when we consider that language is really fundamental to how we interact with the world, how we make friends, how we learn from the world, how we express our worries and our ideas, it's not surprising that DLD actually commonly does co-occur with externalizing and internalizing difficulties. And once again, these can mask the language disorder. So perhaps referring adults will refer on because they see this overt behaviour, but without really giving much thought to the underlying language difficulties. Language difficulties affect literacy, they affect your ability to make friends, your emotional well-being, and DLD doesn't subside with time. You know, we have children with DLD, we have adolescents with DLD, and we have adults with DLD. It doesn't just disappear. And what we find is quite often that they can manifest as really complex psychosocial impairments and mental health difficulties, reduced vocational employment and engagement, and literacy problems. So they're really, really far-reaching. And it's interesting really that Richard said about this cohort of young people, because when I started this research, I would often ask people to just describe, when you think of the typical young person in contact with youth justice, what comes to mind? What do you think of? I used to ask that question an awful lot. And I'd always get, well, the male, age between 10 to 17, low socioeconomic status, perhaps dropped out of school, perhaps a looked after child. But nobody ever mentioned language to me. It was always the same subset of descriptors it would use, and never language. So I'm really pleased and really grateful that you're letting me discuss my work, and everybody's here to learn about it. It's absolutely fantastic. So thank you very much.
Thank you. Great intro. So we're also going to talk about your research in a bit more detail soon. And we're also going to talk towards the end of the webinar about what we can do to help people with DLD, some of the resources that are available. So if you're sitting here thinking, okay, I'd love to get some help to help people, we have some links and we'll share those later on. But Richard, I just wanted to kind of ask you, having heard Maxine do that introduction, have you got any kind of reflections or any questions for Maxine?
Well, I don't know if now's the time to ask a couple of questions that I did have on my mind, actually, about developmental language disorder, because my understanding of this is that it would need to be a level of function in language that's out of keeping with overall IQ. That's something that, for example, if someone has a mild or moderate learning disability and has language in keeping with that, then they wouldn't have a separate diagnosis of developmental language disorder. They'd just have a diagnosis of learning disability. So I guess that's my question, really, that in order to diagnose a developmental language disorder, does there need to be a discrepancy in cognitive testing, for example, with other areas of function?
That's a really interesting question. Thank you, Richard. And I think recent empirical research and observational studies and longitudinal studies have really shone a light on this and how we actually diagnose it now. So language disorder is kind of an umbrella term, really, and it can be split between language disorder and language disorder associated with. So we could have language disorder associated with autism, or language disorder associated with intellectual disability, or some other neurodevelopmental disorder. Now, that doesn't mean that the language in association with doesn't mean explained by. It just means that this is the context that we understand that young person's language disorder. So this discrepancy, this exclusionary discrepancy that we used to have with regards IQ, the research tells us that really that those people with a lower IQ still react the same to intervention. They're still worthy of having this diagnosis of language disorder, because they still can get so much from the intervention. They're eligible for assessment and intervention. And I think Professor Courtney Norbury has done a population study in Surrey a couple of years ago. And what she found is there was approximately 10% of young people with language disorder, and 7.5% of those were what we would usually have classed as specific language impairment, which I think what you're talking about, Richard, where we didn't have this sorry, we had this non-verbal IQ discrepancy. But what she was finding was that there was no real justification for that anymore, with how these young people reacted to intervention and how they changed over time, and also just their overall profile was the same. So there was no need to have that discrepancy anymore. So we would see, as I say, two brackets of language disorder, and then language disorder associated with. But that certainly doesn't mean explained away by the autism or the intellectual disability.
Okay, that's nice, Maxine. Thank you. Let's move on to the research, because we need to have enough time to kind of get our teeth into this paper and ask some questions and, you know, explore what we're going to do with this evidence. So I'm going to hand over to my colleague Douglas, who's going to talk a little bit about the paper and his appraisal of the paper. Before we do, Matt, can you share poll 2 now? Now, some of you guys in the audience will have had a look at Maxine's paper already. And that's great. If you've done your homework, you're going to get extra brownie points. Tell us what you think of it. Tell us to what extent this paper has changed your perspective on developmental language disorders and reoffending. And if you haven't read the paper yet, then don't worry about answering this poll, because we're going to ask it again later. And you'll have a second chance to tell us what you think. We just want to start getting a sense of what you think of this paper. Is it relevant? Is it useful? Is it going to change your perspective, potentially change your practice? Okay, thank you very much, everyone. So we've got quite a positive response already. So the largest response is 8 out of 10, which nearly a third of you have said. Nearly a quarter of you have said more than that, 9 or 10 out of 10. And other people, mostly grouped around 5, 6, 7, and there's 1 or 2 also who've said less so, around 2 or 3. So we'll revisit that later. Thanks, Matt. And yeah, for now, Douglas, over to you.
Thanks very much, Andre. And Matt, I was wondering if you could jump into slide 4 for us, please. Thank you. So I ran a critical appraisal of this paper using the CASP critical appraisal checklist, which I guess some folk may be familiar with. We'll just look at the structure of that in a second. And I also wrote the blog on the mental health based on that appraisal. So if you want a little bit more detail than we've got in these slides, not much more, you can find that on the blog. And it's good to see the questions coming in around some questions about the study population and comorbidities and how we define and understand DLD that we've addressed. So we can add to that list, and hopefully through this session explore them with the researcher being in the room. Now I've just lost the slides, Matt. Do you need me to present them?
No, I can do that. Bear with us.
All right, thanks. So the first thing I suppose when I looked at this study was that there were 2 research questions being addressed in the paper. The first one was just, what is the, if you, back 1 please, Matt, just back 1 slide, that would be great, Thank you. The first question was that Maxine and her colleagues were looking at the prevalence of DLD amongst first-time offenders. And that's a sort of statistic you would want to do some survey-based activity on. But the second thing they wanted to do was to recruit a cohort of people that they could follow forwards in time to detect a link between the existence of developmental language disorder and subsequent reoffending. So that's a sort of prospective observational study. That the right fit for critical appraisal there was the cohort study checklist. So let's skip on one slide, please, Matt. So looking at the key details of any cohort study, the first thing you need to know is who the people are and how they were recruited to the study. The second one was how did they establish the exposure, if you like, in the cohort study? How did we establish whether people had developmental language disorder? And then thirdly, we need to know, well, did they establish the right outcome? Did they have a reliable method for assessing the people's outcomes at the end of the study? So in this case, we have followed the participants for almost a year. Most people were followed for a year, and the ones who weren't, it was only slightly less than that. And we have, I guess, a fairly objective outcome measure in the sense that if people were convicted or not, that gives us a nice binary outcome that we can work with. So Matt, if you could skip on one section here. Now, this slide is going to be in our slide pack, but what I've done is I've pulled the CASP questions off the checklist and just summarized them so you can have at a glance view. And in the CASP method, one of the things we're keen on doing is exploring some of the reasons why you might not be clear about something, rather than just saying, oh, if everything isn't perfect, then we forget about it. Because as I guess we'll probably hear, there are often limitations in how much detail you can put in the published report of a study. However, it's important, I think, to go through this process because quite too often we see things published that might mislead us or that might contain bias. So we've already looked at the first question, the first CASP question, which was understanding the study questions. And we move on then to look at point 2, which is how the cohort of participants were recruited. And I think we've already seen some of some mention of that in the chat. And one of the concerns I had in reading the paper was that some of the participants just didn't participate. They tried quite hard to get a consecutive group of patients, which is good, of participants rather, which is a real strength. But inevitably, there were some people that that weren't able to participate. So we'll ask maybe Maxine to comment on that. But it did seem that there was quite good effort was made to achieve a good cohort of participants. So I was happy with that. And in fact, the only kind of 2 other questions I had about it were how did we get a reliable classification of people with DLD? And I think that relates to some of the concerns that folk maybe have expressed so far around potential for overlap with other conditions. But again, that's something that's inherent in the nature of it, and we can't just sort of rule things out on that basis. So that's just something to remember, I suppose. And the second point at this stage was the 5th point around the potential for confounding factors. And again, potential for other conditions could be involved. There could be things that we haven't thought of. They went to quite considerable lengths to measure adversity, non-verbal IQ, and other things which we know might influence reoffending. But you could never. There might always be something that you haven't thought of or that hasn't been measured. that could be at play here. So that's really something to bear in mind before we then move forward to think about the implications and the findings of the study. So I wonder if we could just pop up poll 3, please, Matt. So I just wanted to get, having given my own view, what the view of the participants were on whether you think this paper provides valid evidence that we can that we can rely on. And you can put yes, no, or not sure, and further details we can discuss in the chat window. Okay. Well, that's a pretty, thanks, Matt. That's a very clear vote in favour. And but there's maybe a substantial number of people, maybe including myself at first sight, that maybe weren't sure about a few things. So I wonder at that point if we could just jump on to the next slide, please, Matt, and I'll maybe just summarise some of those concerns. It should be the slide after that one. So that just summarises the concerns that I outlined just now. But I thought that might be quite a good point to pass over to Maxine, because we've talked through some of these, and it might be a good opportunity to, Maxine, answer some of the questions, particularly around the potential for overlap, with interactions with other conditions.
Yeah, most definitely. Obviously, that is really difficult, and as Richard has said, comorbidity is the norm here, and certainly not the exception. What I did do was, when I started the study, the only exclusionary criteria I had was that English had to be a first language, because I really wanted it to reflect the young people that come through youth justice. Rather than having all these exclusionary criteria, I wanted it to reflect the young people that came through youth justice. So I didn't have any exclusionary criteria. What I did do, though, was I did what we call sensitivity analysis on the data. So I reported the data with the 145 participants that I had. But then I ran what we call quite a few different sensitivity analyses, where one of them was where I excluded all the participants who had a known neurodevelopmental disorder or an EHCP with something noted on it. So all the young people that had autism, ADHD, they were all taken out of that analysis, and I just ran the analysis without those in, and I got the same set of results. Same with the adversity score, really. So the adversity score was made up of 5 different variables, and they included, I'm going from memory here now, it feels like the 7 dwarfs, I can never remember them all, but it was whether or not your parents were in paid employment, whether you were not in education or employment or training, and all these 5 variables. What I did was I ran each one separately. So I put each one of those through in case I diluted actually the effect they had on recidivism. And that didn't make any difference either. And then I also put all 5 of those variables in separately. Now, when I did that, obviously I was overfitting the model, because I only had 145 participants. So to put all of those in separately was really overfitting it. But I wanted to do it just to see how it came out. And once again, I came out with the same set of results. Nothing I did really changed those results. And DLD was always the biggest predictor of recidivism, ranging from something like a 2.4 right up to 2.8, depending upon each set of those sensitivity analyses. So as I said, I did run the model a few different ways to check that I was getting the right results each time, and all the results were consistent. I think with regards recruiting of participants, you are right, it is really difficult. It was a two-channel process really, because some of the young offenders who scored very low on what we call the crime on the crime matrix, they went through what we call kind of a diversionary subset. They didn't go through the youth offending team, so I had to have a separate way that I recruited those young people, because they only met with a worker once for 3 hours. So I didn't really get a chance to build up a good relationship with those young people, though still quite a lot of them did take part in the research. And then anybody who scored 3 to 8 on the crime matrix, they went through the youth offending team. And each youth offending team were really, really good at driving the research forward. The manager in each youth offending team made it part of the young person's kind of initiation to the service, really, that they would be told once the youth offending worker had built up a relationship with them, they would be told about the research and asked if they wanted to be involved. And obviously parents were invited to come to the session, youth offending team workers were invited to come to the session. So we're always going to have that self-selection bias really for those that did turn up and those that didn't turn up. And we can think perhaps maybe some of them didn't turn up because they thought, oh, crikey, language is really difficult for me, I don't want to go to that. Although I've reported on 145 young people, I did see a lot more than that, but it was quite evident as we sat down to go through the measures that they were really, really struggling. So the right thing to do was to stop what we were doing and not count them in the data. So it could actually be an under-representation, of the young people with language difficulties, as opposed to an over-representation.
Well, thanks for that. That's, so an amazing picture of how you managed to get the study integrated into practice there. Tell us about your wellies, how important they were.
Yeah, they were really important, because the young people that just had a kind of a one-stop session, which was a 3-hour session, that it was all built around kind of paying back to society really, and reparation. So what we would do is usually meet for 3 hours at perhaps a care home, and we would do gardening there, or perhaps these I think places have these, what they called, allotments, and some of those are empty, so we used to go and do those up. So what I used to do was just go and take my Wellington boots with me, and a week before the young people came to the session, they would have they would be sent information about the research. So I just turned up to see if they wanted to get involved with the research, and if they didn't, I would just put my wellies on and just help them really. And quite often I'd spend about 30 minutes chatting to somebody, and they'd say, well, actually I really would like to have a go at this, and they'd get involved. So it's just about making those connections with the young people really, and just being involved in what they were doing. It was really important.
So quite literally getting your hands and feet dirty. And
yeah.
I think that it's nice, it's quite a nice metaphor, that, and it addresses one of the sort of fundamental questions here, is around all this sort of the messiness of diagnoses and who's got one, who hasn't, and who's been missed, and what other conditions are available. And that is just real life, isn't it? And you if you wanted to do a study which everything was just focused down on one thing, you'd never find anyone to participate in it. So this is absolutely essential that we embrace this kind of thing. I wonder if we could, Matt, could you quickly throw up the next poll? So I wanted to just think about the extent of the findings, the size of the effect. Do you think that it's important? We can, the broad finding of the study was that people who showed up with DLD were around 2.5 times more likely to reoffend with a year later. Now, which does seem quite a big effect. I just wondered what the feelings of the group were from looking at the paper. Does this look like important evidence to you? Just give us a quick click, and then we'll slide back into the next slide. Do you want to see what folk are saying?
Can I just quickly answer a question? Would that be okay?
Yes, please go for it.
It's quicker for me to say than to type it. Everybody had to have English as a first language. I can see someone's asked about the participants being bilingual. The problem I had was because some went through the youth offending team and some went through this diversionary, I could only collect data that both departments collected. So the youth offending team obviously collected better data than the diversionary team. So I don't have details on the amount of people that were bilingual, but they all had English as a first language. But it's a very important point. Thank you.
Yes, thank you. Matt, could you quickly pop up the next slide? I mean, I do take on board the fact that there was a mass rush to say this is important evidence. I don't want to just say it again, but it's worth saying it, I think. I mean, I think there's something about when you put a study that's an observational study, and therefore there may be some limits around what all we can say. When you've got something that says, look, this group might well be 2.5 times as likely to reoffend, you've got cause for concern in terms of thinking, well, hang on, are we just doing this all wrong? Or is there something, do we need to rethink how we're doing things? The other finding for this group was that around 60% had a developmental language disorder. So those are our kind of findings according to our 2 questions. I think we're probably all on the same page where we think this is an important finding. And probably now is a good time to pop back to discussion of the importance of this evidence. So I wonder if you'd like to kick us off, Maxine, just in terms of your findings. How surprised were you by the findings?
No, I wasn't surprised at all, really. I did feel that that DLD would come out as a strong predictor, perhaps not as strong as it is, as I've found, but I was confident that I was really mindful of the fact that I kept reading research from people like Professor Karen Bryan and Professor Pamela Snow about the fact that DLD is overrepresented in people in young offending institutions. But I was always concerned, well, if we go backwards to when they first come into contact with the criminal justice service, are we pushing them further up that ladder, that criminal ladder, because we're not getting it right at first port of call, really? So I think what I was surprised at was the fact that 60% of the young people came out with the diagnosis of DLD. I think I thought that would be lower. That kind of equates to the young people in young offenders institutions as well. And I thought it perhaps would be lower because we were forcing them up the ladder. So that was my surprising find, really, out of the research. But yeah, definitely, I think going forward, I'm really hoping that people see that there is a role for speech and language therapy in this arena. And the specialism we bring, and just how important these language skills are to the talking therapies that are used everywhere. And as a speech and language therapist, what I want is to make sure that there's equity for all the young people. So people with developmental language disorder, I want them to be able to access these rehabilitation that's on offer.
I think that's absolutely crucial point, isn't it? The equity here. Richard, do you want to have a quick word on the paper before we open up to broader discussions? And I'm seeing loads of questions coming in, so we need to make sure that we run through those questions. But I wondered if you wanted to comment.
Yes, thank you. There are lots of interesting questions, and I think I wonder if some of our participants might also be wondering what I was thinking about the comorbidity, looking at the more traditional psychiatric diagnoses like depression, anxiety, post-traumatic stress disorder, because that's not something that the paper explicitly looks at, but is a well-known comorbidity. So I guess my question to Maxine as well would be, are we saying that regardless of comorbidity, whether the developmental language disorder exists with another disorder such as PTSD or not, doesn't actually matter. They've got that language disorder. They've got that impairment, and perhaps it's that is particularly significant in mediating this vulnerability to recidivism. And the desisters, whether they have depression or PTSD, anxiety, or whatever else, they improve their better language function maybe serves them to desist. Is that perhaps how we think about comorbidity with those other diagnoses, Maxine?
Yes. I mean, it is really, really difficult to tease everything apart, especially when these young people come to us as adolescents, and a lot of these difficulties have gone undiagnosed and unrecognised. It's hard to work backwards and tease this apart. But when you've got language disorder associated with something, you still have that language disorder. You still find that difficult to access those talking therapies. So it is something that needs addressing and something that needs recognising. And as I say, quite often these other neurodevelopmental conditions or these other diagnoses that they have can often mask the language disorder, which is a shame, really, because it does definitely need addressing, and it needs help, and it also needs modification to the rehabilitation that they're given and that's offered to them.
I think that's one of a strength of the observational approach. I mean, I think to explore the ins and outs of all different ways of categorizing participants, you would need much bigger study for a start. And so I think that, in some ways although, yeah, we can't answer definitively all these questions. I think taking that simple, if we're happy with the way that we identified the language disorder, then we've got something important, and it may, that may, just change our perspective on things a little bit. I'm just seeing there's a great comment just now about, I think, Julie, thank you, was saying not just implications for therapies, but just how we all approach young people. Talking with children to resolve problems is relied upon everywhere. So it's maybe something that, it's beyond just this group.
Yeah, I wonder, I mean, that's really interesting, isn't it? What are we going to do about it? And I wonder, Maxine and Richard, if you can kind of respond in general to some of these questions about intervention. So Judy's comment, really interesting. Sinead also talking about, appropriate ways that we can help people with DLD if the normal verbally mediated interventions are not appropriate. Kirsty also talking about animal-assisted interventions, really interesting, thinking about how they might be useful for other groups of young people, potentially also useful for people with DLD. What needs to change in the system? What sort of interventions do we need to be delivering for young people with DLD? And presumably, there are subgroups of young people with DLD and other things going on as well.
Yeah, I think it is really very difficult. I mean, there's a huge disparity, really, I think, in our current knowledge concerning language skills of young people in the Youth Justice Service and the policy frameworks and the services that are there to support them. And I think it's also very challenging as well, because although we're certainly making strides in that area, speech and language therapists aren't always known for working in youth justice. I mean, thankfully that the tide is changing on that now, but historically we're not. So it's really looking about how we can embed ourselves in that service and make a huge difference. I mean, I am a huge believer in all children and young people who present with social, emotional and mental health and conduct disorders should have a full speech, language and communication assessment to get a full profile of that young person's language ability. And then we can establish what their language skills are. We can start with a base level of where they are. We can make sure we work collaboratively together to deliver joint sessions so that these young people are going to get the most out of those sessions. And I think that's really important to get a full profile of that young person so that the MDT are completely aware of that, so that we can really move forward for them. There are other, when I've worked in social, emotional, mental health settings, and I've worked in youth justice, there are some kind of like go-to resources that I've used. I've often used things like Talking Mats. I've found comic strip stories really, really beneficial, where each little piece of information has been put on a sticky note and put down, and then the young people can move them about to make sure they get the right time frame as to when these things happened. Lots of color coding to what somebody was thinking, to what they said, to their emotions, and really making these things that are so important extremely explicit for the young person, and not having that assumption of knowledge.
Richard, do you want to come in? I mean, it feels like we're quite early on in the development of services here that are going to help this group of people. Are there some examples here of speech and language therapists working in youth offender system, working in criminal justice, that we can kind of build on and, you know, spread out across the country?
Well, absolutely. I think it's becoming the norm, I'd like to think, in youth justice settings. What I think is really interesting, perhaps, not to perhaps interesting to everyone, but from a managerial and commissioning perspective, how actually wider or universal provision is achieved. Does it depend on individual leadership within the youth offending service? Where does that speech and language therapist actually lie organisationally in terms of their employer? Should they be employed by the NHS actually, and also, local paediatric teams often provide speech and language therapists to youth offending services. Sometimes they are more closely linked to the mental health team. So I think that there are those questions because they have implication for commissioning, of course, and funding those posts, but also for the really important bits of supervision and joint working and real inclusion in different sorts of meetings that young people in this field have, CPA meetings or other sorts of meetings, so that's a perspective that can be put into different kinds of youth justice service reports, pre-sentence reports, and so on. So I think everyone's on a learning curve, really, and I think that a lot of it does depend on the leadership locally of the youth justice and health services. And I think where there's the will to develop provision, I think it can really happen because there's an appetite for it. And from the comments I've seen, real interest in the Royal College of Speech and Language Therapy, actually, in mental health and perhaps this particular field now. So I think then, I suppose that's the first point. We need to make this provision available and then have a structure that enables effective joint working and incorporating the results of these very valuable assessments then into care plans for a way forward.
Thank you. I think it'd be really interesting also in the time we've got left to talk a bit about priorities in terms of research. So what other questions should we be answering, do you think? If there's research funders on the Campfire this evening, I think, oh, I've got a spare £1 million that I can push your way, Maxine. What would you be doing next?
Yeah, I'm really interested in doing extra research really in this area to move it forward. I think there's a few things that I was unable to look at because I did do other measures than what's reported in this paper. So I also looked at the literacy of these young people, and I looked at the narrative skills as well. I can see some of the speech and language therapists have really struggled to keep up with the questions. They've come in so fast, but I've asked questions about inference and prediction and verbal reasoning, and they are really, really important things that could have been missed that I should have looked at. I only looked at structural language skills. Going forward, it'd be really important, I think, to look at pragmatic language skills, as we know that they can mediate the relationship really between social disadvantage and behavioural outcomes. So that's something I would like to look at. I would like to look at how we can embed speech and language therapy really into youth offending teams, and doing some kind of small scale studies on perhaps response to intervention. So having those tiers, having that universal and targeted and specialist tier, and how a speech and language therapist can feed into each of those tiers, but in a youth justice service. That would be really important for me. And I'm always keen really to listen to what the people working in youth justice would like to find, the questions they would like answering, because they're the important drivers, and they certainly helped me drive this research forward, and without them I wouldn't have been able to do it.
And thinking upstream from there, lots of questions about the role of schools, earlier intervention. What do you think we can be doing in terms of system changes to be identifying these young people before they get into the youth justice system?
Yeah, most certainly. I think, you know, if we think of Professor Karen Bryant's compounding risk model, that this is what she says, you know, there's been plenty of chances really to intervene for this young person before they've got to the youth justice service. And it's a shame that we haven't. And I think sometimes that's why youth justice staff felt a little bit ill-equipped to be able to pick out those with language disorder, because they would say to me, well, actually, this young person's been in school. If a teacher hasn't recognised it, it's really difficult. How am I supposed to recognise it? But as I said before, I really do feel that any young person who has got any kind of behavioural difficulties should be flagged up for a speech and language assessment, so we can get that baseline and know their language abilities. And also earlier on, any difficulties with literacy, you know, so I mean, early stages in school, actually they're teaching you to read, aren't they? And then eventually we turn about 7 or 8, and actually then we're reading to learn. It flips. So if you've not learned how to read, then that reading to learn ship will sail without you, and you'll really start to fall behind. So I think those are other points that we could intervene and certainly hopefully get in there and make a difference.
Thank you. Richard, any final comments in terms of system changes further upstream?
Well, I think that speech and language therapists should be really encouraged by this important publication. I think speech and language therapists should not be working in isolation. I think they can sometimes be a little bit disconnected from other teams, and also not working with each other. For example, someone working as an intermediary in the court setting or doing an assessment for court may not communicate as they should, perhaps, with others working in the youth offending team or the CAMHS team. So I would love to see an end to isolated working and really more integrated working with multidisciplinary teams, with a professional network around children, and actually to see really empowered speech and language therapists do this and be recognised as a really valuable part of the multidisciplinary team.
Thank you. Okay, we're out of time, I'm afraid. So I'm going to draw this to
Poll 5 quickly. Matt, can you jump in with poll 5? We need to know how much our chat has changed your life.
So this one is talking about the paper itself. To what extent has this paper changed your perspective on DLD and reoffending? So this is the one we asked before, but now you've all had a chance to think about it in detail. Tell us what you think.
And just while you're voting on that, if you do want ACAM to provide more DLD events, do please email events@acam.org. The more people we get saying that we want to put on events like this, then the more evidence we will have to be able to show to our board that we should be doing things like this. So I'm just going to stop this poll now.
Well, I think that's even more positive than it was before. We've kind of slightly moved up.
Yep, definitely.
That's great. And the final poll, Matt, and while we've got the final poll up, we'll just say thank you to people for joining us. So thanks very much to the audience. As I said at the start, this is the best attended campfire we've done so far. So really great that you joined us. Thank you for taking the time, and thank you for the lovely comments. And yeah, feel free to tweet at CAMHS Campfire if you're on Twitter. Tell people what you thought of this. And if you've got any constructive, critical feedback, do please email that to us as well. We're really interested in things you think we can improve about the events, as well as sitting here and basking in the lovely thank yous. Big thanks to Maxine and to Richard for coming along this evening, for talking about the paper, for sharing their experience. Really great stuff, and keep up the amazing work. Thank you to Douglas and to Matt and to Celine for their input into the webinar. Lots of resources on the website. And as Matt said earlier on, we've got 2 more of these booked in. If you're interested in PTSD, then you can join us on the 28th of March to listen to Rachel Hiller talking about a new paper. And if you're interested in ADHD, then you can join us on the 25th of May for Stephanie Amy's paper. And yeah, we hope to see you at some point in the near future.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.